This is the last part of a series addressing the topic of diabetes mellitus. The highlighted items with the yellow color represent the topics that we have finished in the previous presentations. We spoke about introduction, physiology and pathophysiology, classification and diagnosis, how to evaluate a diabetic patient, type 1 diabetes and type 2 diabetes, and we spoke in full details the pathogenesis and the drug treatments. And the last lecture was addressing the important issue in diabetes, which is hypoglycemia. The topic of today is the topic of chronic complications of diabetes. Traditionally, the chronic complications of diabetes are divided into three major types: microvascular complications, macrovascular complications, and other complications. Now, the microvascular complications include retinopathy, neuropathy, and nephropathy. The macrovascular complications include coronary artery disease, peripheral vascular disease, and cerebrovascular disease. The other complications, which cannot be categorized as a separate entity, include gastrointestinal genitourinary complications, infections, ocular complications, and oral complications. Before we proceed to discuss the micro and macrovascular, I actually would like to highlight some few issues regarding the oral complications. A very common complication of long-standing uncontrolled diabetes is gingivitis, which is inflammation of the gums. Gingivitis, it can lead to loss of teeth. Loss of teeth will compromise and it will impair the proper feeding and the proper eating of a diabetic patient. And the importance of properly examining the oral cavity when we are evaluating a diabetic patient, that many patients with type 2 diabetes in particular, they might need a dentist consultation, and a dental consultation should be part of the comprehensive management plan in any type of diabetes, in particular type 2 diabetes. Now, the focus of today's lecture will be the microvascular complications of diabetes, and we start with diabetic nephropathy. Now, almost 25 to 45 patients with type 1 diabetes, actually they will develop diabetic nephropathy, and this is a very important cause for end-stage renal disease. When we spoke about the importance of diabetes as a global epidemic, we mentioned that nowadays the most important leading cause for end-stage renal disease is diabetes. And the risk for diabetic nephropathy, actually, it is equivalent in type 1 and type 2 diabetes. In other words, the risk for end-stage renal disease, it is the same in type 1 diabetes and in type 2 diabetes. This diagram, it represents the timeline of diabetic nephropathy. Here, at the initial stage of diagnosing of diabetes, usually the kidney functions are normal and the glomerular filtration rate is normal. Now, as the time goes on, the diabetic nephropathy will start revealing itself by increase in the protein excretion in the urine, but the initial stage of this protein excretion, we call it microalbuminuria. As the time goes on and as the diabetes is not well controlled, the microalbuminuria will be converted into gross proteinuria. And the time interval, as you can see here, from the onset of diabetes until the gross proteinuria and end-stage renal disease is actually about 25 years. This is another table which shows the progression or the natural history of diabetic nephropathy. At the time of diagnosis, usually the glomerular filtration rate is normal and there is no protein excretion in the urine. As the time goes on and if the diabetes is not well controlled, the protein will start appearing in the urine, and we call this the reversible albuminuria. Reversible because it can be reversed once the blood sugar is well controlled. Now, as the time goes on, here the microalbuminuria will start to appear, and if the diabetes is not well controlled, there will be gross albuminuria, which will eventually end into end-stage renal disease. And as we mentioned, the average time for this is about 25 years. But here a very important point which needs to be addressed. the 25 years, this is the natural history for type 1 diabetes. But since type 2 diabetes, in many cases, it is entirely asymptomatic, so a few patients actually might present initially with evidence of microvascular complications, which is diabetic nephropathy. In other words, sometimes patients who are newly diagnosed as type 2 diabetes might have an evidence of diabetic nephropathy. Now, since we are talking about microalbuminuria as a reflection of the diabetic nephropathy, microalbuminuria, which is the excretion of small amounts of albumin, it usually precedes the appearance of gross proteinuria. Gross proteinuria, when we talk about it, it is in excess of 300 milligrams per deciliter. Now, usually the mean duration from the onset of diabetes until the development of overproteinuria in type 1 diabetes is about 17 years. But once proteinuria starts to develop, the time interval from microalbuminuria into end-stage renal disease, it will be no more than 5 years. And as we mentioned, in certain cases of type 2 diabetes mellitus, microalbuminuria and diabetic nephropathy can be present by the time of diagnosis. How can we diagnose it? It is very important that we screen every patient with type 1 and type 2 diabetes for microalbuminuria. And this screening should be done on a regular basis. And for type 1 diabetes, the screening should start after 5 years from the onset of diagnosis of type 1 diabetes. And regarding type 2 diabetes, the screening should be on the initial visit, and the initial diagnosis of type 2 diabetes should include screening for microalbuminuria. Remember, type 2 diabetes, in many cases, it is asymptomatic, and sometimes by the time of diagnosis, you might find evidence of microalbuminuria. Now, the screening for microalbuminuria is done by a test which is called albumin creatinine ratio in urine in a randomly collected sample of urine, and the normal should be less than 30 milligrams. So the screening for microalbuminuria by the test in a randomly collected urine sample, we no longer use the old-fashioned test of 24 hours protein in collected urine sample. We no longer collect the urine volume in 24 hours. It is just one sample of randomly collected urine sample, and we ask for the albumin creatinine ratio in urine, and the normal figure should be less than 30. Now, what is the management and how can we prevent diabetic nephropathy? The most important item in prevention of diabetic nephropathy is achieving intensive control. In the first or the second lecture, we spoke about what are the therapeutic goals. When you are treating a diabetic patient, whether type 1 or type 2, you have to achieve A1C less than 7, fasting less than, or the fasting should be somewhere between 70 and 130, and the peak postprandial should not exceed 180. Now, for patients with type 2 diabetes and who are having evidence of diabetic kidney disease, the latest recommendation address the use of sodium glucose cotransporter 2 inhibitor for treatment of diabetes. Now, for the patients who are having chronic kidney disease and they are having cardiovascular events, remember, in type 2 diabetes, the problem is not restricted to diabetes, and usually those patients are having hypertension and ischemic heart disease. For these subsets of patients who are having chronic kidney disease and evidence of cardiovascular disease, the proper choice is we use the incretin-based treatment or the glucagon-like peptide receptor agonists. Now, for non-pregnant patients who are having combination of diabetes and hypertension, a logic choice is to use the ACE inhibitors or angiotensin receptor blocker. And finally, when the patient is having normal kidney functions and is not having evidence of microalbuminuria, there is no recommendation for primary prevention by the use of ACE inhibitors or angiotensin receptor blocker. In other words, if the screening of the patient with type 2 diabetes reveals that he's having normal glomerular filtration rates and there is no evidence of albumin creatinine ratio in excess of 30 milligrams per deciliter, there is no place for primary prevention. Now, the second microvascular complication is diabetic neuropathy. Diabetic neuropathy, actually, this is the most common type of neuropathy encountered in clinical practice. And this neuropathy, it is sensory motor, but it is a primarily sensory neuropathy. The importance of recognizing patients with diabetic neuropathy is that diabetic neuropathy is a major risk factor for food trauma and ulceration. Because simply, since there is involvement of the sensory fibers, it means that if the patient with diabetes walks barefooted, he can actually step over something sharp and he can have injury of the leg without having the sensation of pain or feeling. If you combine this with the possibility of the presence of macrovascular complications involving the peripheral arterial tree, it means that the injury will not be properly healed because there is a defective circulation. And actually that's why examination of the foot of a diabetic patient is very important, because in many cases of type 2 diabetes, in particular the long-standing cases, we might have both micro and macrovascular. Microvascular complications, it means we are having diabetic neuropathy. Macrovascular complications, there is a possibility of the presence of peripheral vascular disease, and this combination, which is neuropathy and peripheral vascular disease, it will subject the patient to have injury without feeling the pain or without actually feeling that he is injured or having an ulcer. At the very same time, the healing will not be proper, and that's why diabetic neuropathy and peripheral vascular disease are the most important leading causes for non-traumatic amputations of the diabetic patients. The clinical syndromes of diabetic neuropathy include many subtypes. The most common is painful peripheral neuropathy, in which the patient complaint is usually bilateral tingling and paresthesia of both lower limbs, and usually this tingling is painful, and in particular at night. Usually they respond to some preparation of tricyclic antidepressants or gabapentin. Another form of neuropathy, which is autonomic neuropathy, it can reveal itself by orthostatic hypotension and intractable nausea and vomiting. Now, an important part of the diabetic autonomic neuropathy might involve the gastrointestinal tract, resulting in impairment of the normal motility of the digestive tract. And there is a peculiar type of diabetic neuropathy, which is called gastroparesis diabeticorum. And in this form of gastroparesis, the patient might complain from intractable nausea and vomiting. And in this case, it is very important to differentiate this gastroparesis from other causes, for example, like diabetic ketoacidosis and other causes of nausea and vomiting. Another form of diabetic autonomic neuropathy is diabetic cystopathy, which actually it is the autonomic involvement of the bladder, and it leads to bladder dysfunction, and the manifestations include dribbling and incomplete emptying of the bladder. And finally, as a part of the diabetic autonomic neuropathy involving the digestive tract, we have diabetic diarrhea, because the altered motility of the digestive tract will encourage or will actually precipitate bacterial overgrowth, and this is an important cause for diarrhea in diabetic patients. Finally, in conclusion, I'd like to show you a comprehensive plan for management of patients with diabetes mellitus. Now, remember that management of diabetes mellitus, it's actually a tripod. The most important thing is to achieve glycemic control by the diet and lifestyle and exercise, and of course, the use of medications, whether the oral medications or insulin. Number two, remember that in a particular type 2 diabetes, usually the patient is having associated conditions. Might have hypertension, hyperlipidemia, obesity, and coronary artery disease, and the management plan should include treatment of these associated conditions. And finally, you have to pay attention for the possible complications. So we have to screen on regular basis the possibility of retinopathy, neuropathy, and nephropathy. The same thing here, which is represented by this table, the tripod. Number one, lifestyle changes, healthy diet, exercise, weight control, smoke cessation. The second item is what I call it the control of modifiable metabolic factor. By this item, I mean proper control of blood glucose, proper control of lipid when they are elevated, proper control of the blood pressure when it is elevated, and it is also important that patients with type 2 diabetes, they take small dose of aspirin for prophylaxis against cerebrovascular strokes and coronary events. And finally, the preventive care, which is screening for the complications. Patients with diabetes should have regular screening for the presence of albuminuria. You perform the albumin-creatinine ratio. They should check an ophthalmologist every 6 months to make sure that they are not having retinopathy. Podiatric examination means the proper examination of the feet, proper care of the feet, because the micro and macrovascular complications can lead to ulceration and amputation. And dental checkup, this is very important. Remember that diabetic patients are liable to have gingivitis and loss of teeth. And the last two items in the preventive care, they should receive the influenza vaccine and the pneumococcal vaccine. This concludes the last lecture of a diabetic series.